Okay, welcome everybody. I see some people are still joining and that's awesome. Thank you all for being here for our webinar on epidemiological modeling and machine learning for COVID-19. My name is Paul Kennedy. I'm Zindi's community coordinator, and I'm very happy to thank a number of organizations and individuals that have helped make this webinar happen. So I'd like to acknowledge Our Ladies Cape Town and the Cape Town Machine Learning Society, both of who are co-hosting this meeting with us. I'd also like to thank our panelists, Assistant Prof Brooke Nichols, Assistant Prof Elaine and Nsoesie, and Prof Wim Delva, as well as our facilitator, Jono Whittaker. Before I hand over to Jono, I'd just like to briefly touch on why we're hosting this webinar. It's in this rather strange time of COVID-19. We've struggled, as many organizations and individuals have, we've struggled to find ways to make ourselves relevant and to try and make a difference in the fight against COVID-19. Machine learning and AI hold a special power to really make a huge difference in big complex challenges like this. And we have tried a number of ways at Zindi to try and address this problem, or at least contribute in the fight. And that's really what has led us to this webinar, is a hope that we can really make some small difference. So thank you all for being here, and I hope you enjoy it. I'm going to hand over to Jono now.
Thanks, Paul. So hello, everyone. My name is Jonathan Whittaker. So I'll be giving a quick introduction to the competition and the context, and then I'll introduce our three panelists and hand over to them to speak to us briefly. And after that, we'll have a time of question and answers. So during the first few sections, if you have questions, feel free to put them in the chat or in the YouTube live stream chat. We'll be monitoring that as well. But we'll keep that until after all three of our panelists have spoken first, and then we'll start the questions. So that's how it's going to flow. So first up, what is the challenge that we're talking about? So for those of you who haven't seen it on Zindi, in early March, we launched a AI4D global COVID modeling challenge. And the background of this is that, the virus was making all the headlines. There was 20 times less cases than there now, but it was already scarily large and growing. And so everyone was scrambling, thinking, what can we do? How do we help? And we put this challenge together for a number of reasons. So it was a way for people to engage with the data and to try their hand at forecasting. And yeah, so we launched it in early May. It ran until April. And the novel thing is that the scoring period is still ongoing. So the goal was to predict the future. And so when it closes in, I think, the 8th of June, that'll be when we now evaluate the predictions made by the participants back in April. So the goal was to try and forecast how the number of deaths in different countries would change over that time. So it's a very tough challenge. And myself and anyone else who looked at the problem will have encountered lots of difficulties, because unlike cases where there's really lovely, beautiful data sets that you work with, the real world is very messy, and the case numbers and even the death numbers for this outbreak have been not as beautiful and clean as we'd like. There's lots of noise in the data. There's lots of trickiness around how you measure and quantify something like this. So that presented a challenge. And then finding good extra data to feed into these models, where people are, how they clustered, what the travel is like. It's very tough to nail down that sort of data. So there are many challenges that we encountered. And then it also is an interesting one, because it's not the same as maybe the machine learning contest flow that we used to. And so one of the reasons we're having this webinar is to hear from people who work with epidemiological data all the time and can share a little bit about how they address the kinds of challenges that we all experienced as we attempted this competition. So I'm very excited to see what our experts have to say. So let me just run through our panel. We have three lovely people here today to share their knowledge. So first up is Dr. Brooke Nichols. She has a background in health economics and infectious disease modeling, and is an assistant professor at Boston University. She's also a principal researcher at the, I just need to get this right, Health Economics and Epidemiology Research Office. I think I got it right. So her research focus is geospatial modeling with respect to HIV, but she's now working with South Africa and I think Zambia as well, doing some COVID modeling to inform resource allocation and response. So really looking forward to hearing from Dr. Brooke on the ground information on what's being done and the differences in approach with something like the dynamic modeling that they're using compared to the kind of curve fitting that we're used to in the machine learning world. So that'll be our first speaker. And then following her will be Dr. Elaine Nsoesie, also an assistant professor at Boston University. She is a Boston University data science faculty fellow and a data and innovation fellow at the Directorate of Science, Technology and Innovation. Her background is maths and statistics and computational epidemiology. And among the many things she's worked on is influenza forecasting and some other infectious disease work. So we're going to be hearing a little bit more about best practices on curve fitting and dealing with these diseases and how we try and predict them into the future. And then finally, we'll be hearing from Professor Wim Delva, who's a senior data science consultant, who I think has a background in medicine, actually trained as a doctor, but has moved into epidemiology, also working on HIV, and more recently is going to be sharing about the current project that they're working on with Anglo American, what they're doing, how they're trying to respond to the coronavirus outbreak. So those are our three panelists. I'm going to hand over to Dr. Brooke first. Over to you.
Thank you. Awesome. Thanks for having me, guys. So first thing, I know that a lot of these data science challenges are very data focused, which makes sense. But I want to kind of put this in context in terms of how we use these kinds of things in dynamic transmission modeling, which is not exactly the same thing as curve fitting and statistical modeling. So it's a different approach, and I'm going to talk about the key differences between these two and how it applies to COVID and how you might think about this challenge going forward. So what is dynamic transmission modeling? Basically, this is when we use a set of equations that are going to describe a dynamic process between multiple health states. So each of these health states are mutually exclusive. So someone is either can only exist in one state, and then how people transition between states are generally what we parameterize or what we make assumptions about or what we observe in real life. And the rate at which people become infected or the infection risk is dependent upon a few things. One is the number of infectious people there are at any given time point. So if you live in a country with 10 million people and 1 million people are currently infectious, you can imagine that you're quite on quite an exponential curve. How long people remain infectious for. So if people are walking around infectious for 2 weeks without knowing it, that's a much different scenario than if someone's infectious for 2 days. The number of contacts that people have. So if someone, if on average in a population, people have 5 contacts per day or 100 per day, that makes a huge difference. And then the transmissibility of the virus given contact. So what is the likelihood that, if I'm standing next to Elaine, what's the probability that she gets infected? Should we stay next to each other for a certain amount of time? But what's interesting and kind of useful about this dynamic transmission modeling is that it's inherently visual. So we can actually see all the health states and think about how people might transition from one state to the next. So I'm going to show you just a very brief COVID dynamic model to give you an idea of what this looks like. So people start out susceptible. So in theory, the whole world, the problem with COVID is that the whole world is susceptible at the same moment, theoretically, which means that we all have the capacity to then become infected, which makes this a much bigger problem than a virus that's been circulating for a long time, like flu. So if you're susceptible, then you can progress through what we call an exposed phase, which really you're infected, but then you might not have symptoms yet. And so we wanted to make sure that there are several stages of being exposed because, for the first few days, the virus is still, you're not infectious for the first few days once you become infected. And then as you progress through this stage, you become infectious, but you're not yet infectious. but you're not yet symptomatic, sorry. So that's sort of at the end of this exposed phase. And then should you develop symptoms, then you go into this infected and symptomatic stage. And so this all flows together because susceptibles then interact with those who are infectious, and then that grows the pool of that. That is what modulates this whole transmission dynamic. And then in the model, we can assume that once you're infected, you can then recover at a certain rate. And we assume that once you're recovered, you're no longer, you're immune, you're out of the population. We know that with COVID, this might not be the case. And the duration of immunity is unknown at the moment. It might depend on how severe your infection was. But for simplicity's sake, we're sending you out saying you're good. And then another pathway people might take, another distinct health state, is that people might become infected and then need hospitalization. And then someone can recover from hospital and then get better. Someone in hospital could then need to go to ICU, and then they get better, and then they're recovered again. Or they can go to hospital, go to ICU, and then they could die. So this is like very basic representation of an SEIR model for COVID specifically. And so how this works, so instead of statistical fitting, this is actually solved using differential equations. And all the differential equations tell us is that basically it enables us to see how many people are in each compartment and each of these health states at a given time step t. And so instead of using the data explicitly to project forward, the data is actually used to estimate parameters within the model. And so this rate of change from one state to the next is what we can use the underlying, the case data, the death data, et cetera. And so in terms of how to use this, where do we fit this, fit the data into the model, is that the model, there are a list of knowns. There are things that we currently know from the science that's been published, but there's also some really big unknowns. And one of the really big unknowns, for example, are, what is the effectiveness of a given mitigation strategy? So here's an example of a model. There's a link at the bottom where you can play with this yourself from the Mir lab in Basel. And so the dots represent data. So these are actual data points from South Africa. The purple is number of deaths per day, cumulative deaths. The yellow is the number of cumulative cases. And you can already see, so that like here, the death data is tracking really nicely. If we assume a certain up to a certain point, but the case data is all over the show. And I'm sure that, when using this challenge, you probably noticed, or when trying to address the challenge, that there's this discrepancy based on the number of tests that are done and how testing is done. There could be a really huge discrepancy, and it doesn't really track well the data in the cases. So in all the modeling we've done so far, we're trying to fit to the deaths because we assume that to be a more complete, more likely to be a more complete data set than the case data specifically. So in a way we can, and so when we're fitting the model to data, then we say to try to figure out what is the effectiveness of these mitigation strategies. Let's say I put in the model, oh, well, what if the lockdown in South Africa was 10 to 20% effective? Well, the model tracks pretty well up until a certain point, and then we're overestimating. So that means that maybe the effectiveness measure is doing better. So in the model, you can throw in something else and say, well, what if it was 70 to 80% effective? And then you see that the model is now under predicting true deaths. And so you can sort of run with these models through various different assumptions and then try to fit your curves to this. But it's important that we're actually fitting this, we're fitting a parameter in a model that describes the dynamic system. So I think, this is sort of the key difference when we're thinking about differences between statistical modeling, machine learning, and this dynamic transmission modeling. So then, just for argument's sake, maybe the effectiveness and the mitigation strategies, assuming that's our only unknown in this model, which is not true, is 40 to 50%. We track so perfectly on the death data. And then we say, okay, so, this is like a way to solve for X in a way. And so if you want some beautiful visualizations on SIR modeling specifically, here are a few links that you can look at. I'll leave that up for a second. One from the Washington Post, where you can actually like look at one individual bouncing back and forth, and this is sort of a visual representation of one of these models. Another one is a basic SEIR model, where you can really see how the parameters interact with each other. And then finally, the visual that I just showed from the previous page, the COVID-19 scenarios.org, then you can actually look at a COVID model and play around with that for your country. So you can think about how the statistical data and how the curve fitting might intertwine with some sort of dynamic disease modeling. Thanks.
Thank you so much. Those links have been in the chat, but we'll also try and share these slides later. Thank you so much, Dr. Nichols. That was excellent. We're now going to go to Dr. Nsoesie.
Thank you, Jonathan. So I'm going to talk a bit about curve fitting. Most of you already use curve fitting approaches. So when you use curve fitting approaches, you can also incorporate some of the interventions that Brooke talked about. But this requires you to actually write your own equations, and you won't find a lot of this over the shelf. So if you go to a machine learning package in R or Python, you're probably not going to find this information in there. So you have to write some of that information out yourself. So some of the things to think about when you're doing curve fitting is data, your model, and your confidence in your model. So data, one of the questions you want to ask is how complete is your data set? So can you account for underreporting? As you probably know, for coronavirus, a lot of people get affected, but not everyone shows symptoms. And so there's underreporting across the board, across every country. So should we be using case data when we're modeling coronavirus, or should we be using death data? And a lot of people are using death data because underreporting for deaths is a lot less for most countries. But it can still be significant for countries where deaths are not being reported on time. So another question you want to ask is whether the data is timely. So is your data up to date, or are you missing reported cases or reported deaths in your data? So when it comes to modeling, there's several different approaches that you could use. There are regression, well, all of them fall into regression models. You can use count data models, so things like Poisson or negative binomial models, but you could also use machine learning approaches like support vector machine regression or random forest regression. These are all things that you can use. I really like ensemble modeling because you have all those different weak predictors and you can all put them together and get more accurate predictions. But similar to what Brooke was showing, where you have to fit your data or fit your model to the curve before you can make any predictions. So you want to make sure that whatever model you're developing captures the trend of the current trend of the data, whether it's deaths or cases, that it captures that trend as accurately as possible before you can make any predictions using that model. So a few things to think about. So when you fit your curve fitting model, you have your dependent variable, which can be the number of deaths, and then your independent variables could be things or factors that you assume or know have an impact on your dependent variable. So this could be things like the number of hospital beds. It could be the number of nurses and doctors in the population. You could also include demographics, so the age of the population, and prevalence of underlying conditions. So how many people or what proportion of the population has cardiovascular disease, for example. Some of this data can be challenging to find, the independent variables. But I think they're more readily available for most Western countries than African countries. But there are sources that you can look at, and some of it might involve estimating into the future because you might have data that is several years old. The most recent data set might be from 2014 or so. And so you have to think about how do you update that data to the current time point before you can even use it in your model. So the last two things I want to talk about, so uncertainty and communication of results. So when you develop your models, it's always important to think about how to capture confidence in your predictions. For a lot of machine learning approaches, so things like supervector machine regression and random forest regression, you can use quantile regression to quantify confidence in your predictions. Providing a confidence interval is very useful because you know that whatever estimate you're making is not 100% accurate. And so when you give someone a confidence interval, they can tell how much certainty or uncertainty you have in your estimates. And the wider your confidence interval, the less confidence you have in the estimates that you're producing. And the last thing to think about is how to visualize your results and how to present those results to people who might not understand your model, might not understand your data. So you want to think very carefully about visualization. Some of the examples that Brooke presented, things that you can look into, because the way they visualize the models are very easy for people to understand. People who have no computer science or no public health background can look at those visualization and understand them pretty well. There are lots of visualization tools online. I have some of these on the Data Science Africa GitHub page. We have visualization tools, presentations, giving you examples, and even Python code that you could possibly use to learn more about visualization. So I think that's all I have. I didn't have any slides, but hopefully people have interesting questions.
Thank you so much. Everyone, I've dropped a link to the Data Science Africa GitHub in the chat. So that's one place to go check out. Thank you for sharing that, and thank you for pointing out the importance of communication. We'll talk more about that later, but that's like one of those key steps. It's so important. All right, we're finally going to go on to Wim, who's going to share a little bit more about his project. So over to you.
Thank you. Paul, will you help me with the slides?
Sure thing. Let me just set that up. Should be shared now.
Okay.
Great. Go ahead.
Thank you very much. Thanks. So it's only 3 slides, so it shouldn't be too long. But thank you very much to the previous 2 speakers. They're making my life much easier because some of the things I thought I would have to explain, I now can go over much quicker. So in a nutshell, a few weeks ago, I was contacted by Anglo American, a big mining company that is active in about a dozen countries in the world, to ask if I can help them with their COVID modeling. So internally, they have a lot of questions around what's going to happen to their business, to their operations, to their staff, to their contractors. They need to keep people healthy. They need to also keep their business running. And they want to know at any point in time how many people, so if you can go to the next slide. They want to know at any point in time how many people can we reasonably expect to be healthy enough to show up for a shift. How should we adjust our projections and expectations for the amount or the kilos of gold and platinum and coal that we're going to dig up. How many people should we provide safe spaces for that they can quarantine? And then for those who get sick, we need to prepare for hospital beds, for ventilators. There's going to be sick leave. Also, if in a mine, it's not the case that, so in some spaces, the fewer people, the safer, because the fewer people, the more space between people, and therefore less likely transmission. That is true if that's the only thing you're worrying about. But in a mine, things can get very unsafe if there is not a critical number of co-workers present to man a machine or to monitor safety of others. So there's a subtle balance between spreading out thin enough so that you limit transmission risk and spreading out too thin and then you increase risks of other occupational hazards. So we can go to the next slide. So the modeling approach that we've taken is very pragmatic. We really only had a few weeks to produce results. And so what I did is I did a quick survey of some of the earliest models that were published in authoritative journals. This is a model that was taken from a paper by Kissler and colleagues that was published in Science. And so that's one of many proposed models that have been fitted to data. It looks a little bit like what Professor Nichols has shown. So we again have this class of susceptible people. There's a force of infection that is driven by infected people that pushes people towards the E class of exposed but not yet infectious people. And then from there, the way that this group modeled it, they say, well, essentially there are three things that can happen to you. Either you get infected and you recover fine, that's the top row, or you get infected and at some point you need a hospital bed, that's the second row, or you need a hospital bed and then later on you need a critical care unit, that would be the bottom row. So that's a fairly basic model, and then those Greek letters then indicate the parameters of the model, and that if, by tuning them you can make bigger or smaller epidemics and have people stay longer or shorter in hospitals and in ICU units. So that's the starting point for our modeling approach. We can go to the next slide. And so there's a number of things that we now need to worry about and work with to turn this starting point into something that's valuable and usable for the client. First of all, we need to ask ourselves what data are available. So we've already learned from the previous two speakers that there is mortality data, there is data on the number of new confirmed cases per day. We also have, for many countries, we know how many tests were done on that particular day. And those data points touch on the question of, so I see that there's I think I added something to the slide between the moment I shared the slide and now, but it's fine. So under 2, there's, on my slide at least, there's also observation process. So what we observe is the result of two things. On the one hand, there's the disease transmission dynamics. That's the true underlying mechanism of the epidemic. But then there's a layer on top of that, and that is what fraction of the things that are happening in the real world actually turn into data that get reported or that get summarized. And so if you have a massive ramp up overnight of first doing 100 tests a day and then all of a sudden you do 10,000 tests a day, obviously you would expect that once you start testing more, you would find more cases, but that's not necessarily means that all of a sudden transmission was much more active. So if we're trying to understand the dynamics or we're trying to fit a model to data, we have to worry about getting the intrinsic transmission parameters right, but also we can say, well, there is an observation layer, there is a healthcare seeking layer, and we also need to worry about getting that right. Because what we observe is the result of those two processes. The model that I showed in the previous slide, it just showed that if you get infected, you will recover. It has this big letter R. It doesn't say if recover means, so typically recover means you're no longer part of the transmission process. But is that because you're dead or is that because you're fine and you can carry on as before? The model doesn't explicitly say this. So we will probably need to split that out and say some people recover fine and some people are no longer part of the population because they have died. Another subtlety, and that Brooke showed nicely, is that you can move in and out of ICU. So it's unlikely that you go straight from your ICU bed to home. So probably at some point when you are fine, you will be post-ICU, but still in hospital. The third one is, and that's of course something that the client is very interested in, is what can we expect from various interventions? If a country issues a lockdown policy and social distancing measures, what can we expect? And what if this thing then gradually gets taken away again? How will that pan out? That's some of the projections that they're most interested in. And also referring back to the first speaker, indeed, there are potential extra complications where you can say some people are not yet symptomatic and they already start transmitting, and some people stay in this asymptomatic stage. So even they never really develop symptoms, but they're still infectious. So we need to try to build a model that we think captures the key features of the epidemic and the response to the epidemic. In the mining context, there's also worry about, are we capturing some of the other variables that may play a role in the clinical reality? So people with lung disease, people with diabetes, people with HIV may have different prospects in terms of probability of getting infected, probability of landing in hospital, and probability of dying. And if that's true, if these parameters are not universally true for everybody, then we need to think about, can we build a model where we stratify the population in people with and without those risk factors? I think the answer is hopefully at some point we will, but right now we don't have enough data to really justify that extra complication. Once we've decided on a model diagram and we've matched equations to it, we then need to obviously write code to implement it. And then the fairly computationally intensive exercise of fitting the model to the data. Brooke explained it very nicely. So it's essentially, in this case, you can do a trial and error. You can sweep through the parameter space and only retain those parameter values for which the model output matches the observed target statistics. And once you have this family of models that seem to mimic the observed reality well, so it's probably not going to be a single value, it's going to be a whole suite of values that all jointly fit the data equally well. Once you have that, you can then take that forward and ask questions in the future. What do we expect to happen if people behave in this or that way over the next few months? And then obviously at the end, once you've done your simulations, there's a step of reporting and summarizing your findings. So I've spoken more than 5 minutes, I'm very sorry, but this is the flow of things that we have planned to do in the next few weeks, and for which we are welcoming applications for an intern. And that intern would be working with myself and 2 senior colleagues on this project. So I think there's a post on the Zindi discussion forum where people are encouraged to submit their CVs to Zindi if they want to intern on this project. Thank you.
Thank you so much, Wim. I think we're quite on time actually, so no worries there. Okay, everybody, we're going to go into question and answer session now. So I see there's a few questions already in the chat, and I'll start passing those on. But do feel free to add to those, and we'll get to them in time. So first one up from Mohammed, he's asking a question. Given the different social dynamics of each community, how do we use, or can we use data from previous infection spread cases to create a more customized model for different places? And I'm not sure if this is different diseases or just earlier COVID infections. And then there's a little extra follow-up. How about the use of geospatial data, like urban planning data, etc., for customizing a model? So I think that's addressed to everyone, but the geospatial, especially for Brooke, if you want to speak to that.
I can start off with a geospatial question. I think that's a really good point, and something that we are trying to take into account within some of these models. I'm going to share my screen again for just a second because I think this is an important point. I have an old presentation that might be useful. So, for example, this is against Gauteng in South Africa. Oh my gosh. There we go. And so this is underlying social vulnerability index, which takes into account multitude of different factors. So this would be like how close people are living together, the amount of the use of public transport, the use of communal resources. So basically, this is also a very good proxy for contact rates, because if we're living close together, have communal resources, the number of people you see is higher. And so these are like some really key dynamics that make a huge difference. And also, these are not quintiles, by the way, these are categories, but if you look at the population pyramid, sort of by each of these areas, so these yellow areas are where people are, there's a large concentration of people that are highly socially vulnerable, also have a very different age distribution than those in the highest SVI categories. And so high SVI categories also means that a larger proportion of people are going to end up in hospital compared to those in the lowest SVI categories, just because of the age distributions. And also, as you brought up, because the contact rates are different, our understanding of the reproductive number, or how many people one person goes on to infect in a fully susceptible population, then differs by each of these groups. Again, these are not quintiles, these are categories. But we can expect, because the contact rates are higher in these certain areas, that the average number of people one person goes on to infect is then higher than those who are living further apart and have the ability to isolate. So with regard to, I mean, it's a very good question and something that we're trying to take into account, but I think it's an essential piece as the person brought up. Thanks.
Perfect. Thank you very much. Super duper interesting. I have a follow-up question on that data, which is that, so is that social vulnerability index available everywhere, or just in certain locales, or just in South Africa? And ahead of that as well, what other data are we missing that's like that and would be useful?
Well, that's proprietary data. Oops. But there are other data sources that map really closely. So just income data alone is really predictive of SVI category as well. So if you look at National Living Index and the national income distribution, that is also extremely predictive of SVI. So it's a perfect proxy with lack of SVI data.
Thank you. All right, Thomas has a question for Wim specifically. So it's how did you, or what are the important hyperparameters in the model that you were showing? And then when you're looking at different countries to determine this model, do you look at all of them, or how do you account for the fact that countries differ when you're trying to find those parameters for the model?
Okay, thanks. So I think that the word hyperparameter is typically used in a machine learning context. So I'm not 100% sure if we are speaking the same language here, but let me try anyway. So the way I would interpret it is you have the parameters of the model. Those parameters need to be estimated. And often you do that in a Bayesian way. So you say, I don't know what these values should be, but I have some guesses. So I'm going to construct a prior for those parameters, and I'm going to sample from the prior, and I'm going to apply some sort of filtering mechanism to end up with so by comparing it to the model output to the data, and whatever sticks is going to be part of the posterior. So you end up with a posterior distribution of these parameters. So in that, if we agree that that's a good analogy, then the hyperparameters would be the parameters for those prior distributions. And so I have previously used fairly naive prior. So sometimes I just use a flat distribution, and I say, well, the rate of transmission, sorry, the rate of moving from compartment I to compartment H, that means how long does it take before you need a hospital bed? I'm not sure, but let's say between 4 days and 14 days or something. So that's going to determine the hyperparameters for that particular parameter. I don't know if that's helpful.
Thank you very much. Yeah, I think that does help. But Thomas, if you have follow-ups, you can share them. Okay, Selena asks, and I think this is for everyone, but particularly the dynamic modeling side, why the emphasis on hospitalization and ICU stages? Is it for hospital planning purposes, or is there some underlying assumptions about how diseases are being spread in the hospital?
So from the work that we've done so far, this has mostly been to account for resource needs. So purely the number of ICU bed days needed for capacity purposes.
Great, thank you. All right, then another one, maybe Dr. Nsoesie, you can answer this. When you're talking about independent variables to add into your models, what data is missing? Is there data sets that we wish we had or that we might be able to generate as a community that would be helpful inputs to those kinds of models?
I think one data set that's missing and would be difficult for communities to just generate by themselves is prevalence of some of those risk factors. We know that hypertension and diabetes are increasing in most of sub-Saharan African countries, but we don't have good data on the prevalence of those conditions.
Okay, great. Thank you very much for that. All right, then Selena has a question, I think, to get us all a bit more combative. How do the two approaches compare? So this is dynamic modeling versus curve fitting, which is better? But also, I think she's just asking more broadly, which have worked in the past, when would you use one or the other? And are there reasons we have a preference for one or the other?
I can start. I think for influenza modeling, people have used both of them. And sometimes the SR models tend to, if you're doing long-term predictions, they tend to do better than the curve fitting models, while the regression models would do pretty well in short-term forecasting in most cases.
Great, thank you very much.
I agree with that.
Perfect. Okay, so there is a use in the very short term of those curve fitting models.
So and it's also, so sometimes we include curve fitting models, to inform the dynamic models as well. So it doesn't have to be this or that, but they can also be working together in some instances.
Great.
I also think it's fair to say that on average, the curve fitting models have fewer parameters than the mechanistic dynamic models. So if you know almost nothing about the underlying dynamics, it's pointless trying to build a model for the underlying dynamics. And then a curve fitting model would be sensible. But if you understand the underlying dynamics well, it would be weird to ignore that and say, I'm just going to fit the curve of the observed data.
Great, thank you. All right, another question for all three panelists. And this one is inspired, I think, by your backgrounds. How much can we learn from past epidemics or outbreaks like HIV or malaria or influenza? How is COVID-19 too different, or are there lessons that we can take from these past outbreaks that we've studied and that you've all studied very in depth?
Brooke, do you want to go first?
Sure. I think a lot of maybe, the methods have been developed in most instances from previous disease outbreaks. But in terms of, I guess the process of understanding, this is more like outbreak epidemiology than anything else. So maybe early on in the HIV epidemic would be something similar, but sort of the whole disease dynamics and transmission modeling of HIV is just leaps and bounds different. In a way, COVID is a lot simpler than HIV, a lot fewer parameters involved, which makes it almost easier to quantify and also easier to understand what the uncertainty is and what parameters are uncertain. But then do you have other thoughts on that?
I agree with that. I also think so. A huge difference is that they work on very different timescales. So epidemics, HIV epidemics play out over decades, and COVID epidemics play out sorry, over weeks and months. But there are lots and lots of parallels. So all the challenges of missing data, of biased samples, of the sociology and the ethics, of getting the workforce ready to respond, all of those things that we've had to deal with in the HIV epidemic come back in this COVID epidemic. So that also then means that lessons learned are, a lot of these lessons are transferable. And I think we are seeing that. We are seeing lots of countries in Africa that are building on how they've responded to the HIV and the TB epidemics and Ebola epidemics. They're using that muscle to now respond to COVID.
I think another thing that's COVID is new. And so it's different in the fact that we're learning a lot about it as it's evolving. So we think we know something and then, get new information, and what we thought we were very confident about, we're no longer as confident about anymore. And so that changes and affects how we model it as well.
Great, thank you. It's fun that we do have this experience of past epidemics as well. Okay, another question maybe for all three of you, in terms of, so far we've talked about these models and strictly looking at trying to predict and anticipate what's going to happen. But I know that some of you have been working on the response as well. So my question is, do you think there needs to be a difference between the response for maybe an African context, sort of sub-Saharan Africa, where you have very rural populations, very spread out populations, and should the response there be different to maybe a more industrialized country?
So this is something that we're thinking about quite a bit. I think one of the most important things, and that we've seen in South Africa in a way, was the importance of early mitigation. So I think the President Ramaphosa announced the first set of mitigation measures when there's only 116 confirmed cases, and the full lockdown started when there was 1,000 cases confirmed. So that's pretty remarkable, and I think that was the right strategy to sort of push out and slow down the rate of spread. But in terms of the more rural communities, I think you make a good point. This is something that we're doing through our geospatial modeling in Zambia, is to say, well, instead of individual isolation in your own home, to actually have community level isolation, so that you're isolated with your community instead of your household. In a lot of contexts, that just makes so much more sense, and it's something that we're exploring. So that the approach can be different, and for sure it should be.
Amazing. Do you have resources on that you could share? I'm just thinking, I know some people in Zimbabwe trying to look at stuff like that.
As soon as I have more to share, I'm more than happy to share it, but I have to write it up properly.
Fair enough.
But you can put me in contact with people. We can think through these problems together and share what the approach we're taking.
Okay, probably will do. Following up on that, we have a question from someone asking about, are there open resources and public data sets that data scientists can use to do their own modeling and work on how can the data scientists wanting to make a difference best get involved? So I think that's two questions. Is there good data for us that's open, and how can we get involved as a sort of data science community?
I'll go first. We've been trying to collect data across all African countries, so we have a GitHub page for that, and we've made some progress, but it's also challenging because what we're trying to collect are demographic information, but also location of cases, travel history, and current condition. And so we have countries that have reported that at the beginning pretty well, and then not reported so well as the epidemic has progressed in their countries. But we still need people to help collect as much information as we can get access to. Some of this information is not available on Ministry of Health websites, but it's available on press conferences that the presidents or ministries of health are doing every day or every week in those countries. So it would be really useful for people who are interested in helping with data collection to contribute to that effort.
That's so great. Thank you. Is that the Data Science Africa GitHub?
No, that's on the, let me just send it to you.
Great. We'll share that in the chat, and then that's nice because then we have a place to look at. Okay. Other suggestions for data sets and responses?
I think the mobility data sets are really interesting. I know that not all of them are as relevant as others, depending what country you're in, especially like the Apple mobility data, like gives you some about one part of South Africa that uses iPhones. But it's been really, you know, in a way, it's really useful from the modeling efforts to understand how this mobility data works, and then the transition between provinces or within a province to actually understand those dynamics to be able to better parameterize geospatial models is really useful. And it's too much work almost for any modeling team to do that, and the modeling that they're doing on top of that. So that's sort of a huge, I don't know what other mobility data sets are publicly available, but maybe some other people on the call do. So if you can get Vodacom or MTN, for example, would be really useful. And also understanding how, I mean, I haven't done any of this work, so this is definitely out of my game, but in terms of what I would be really interested in figuring out is if we can mine social media posts in some way. And I'm not a machine learning expert and I have no idea how to do these things, but to understand how sentiments and what people are posting about COVID, how that relates to the rate of spread. To see if we can like get ahead of it in some way. And that's something that I would love to be able to include in the model, but I have no idea how to do. It seems like a perfect challenge for you guys, or Elaine, you can maybe you've been thinking about this, but I think you know
we have
include that in a dynamic transmission model if you can parameterize it using that data. So
we've been collecting data. One of the challenges with ongoing epidemics is that there's so much excitement, so we get a lot of noise. So
yeah.
it's kind of hard to figure out when that data is useful and when it's not useful, but it's something that we're trying to figure out. Yeah.
Cool.
I'd like to add something as an answer to the question of how can data scientists help. And I don't know if I speak to all the modelers out there, but before long, you end up with a model where you have 20 plus parameters that all are fairly uncertain. And so the challenge of fitting this model to data is becoming computationally quite intensive. If you pretend that you know a lot that you actually don't, you can keep it artificially low in computational expense. But if you are actually saying this is a 30-dimensional parameter space that needs to be explored densely, not sparsely, but densely, becomes computationally very expensive. So coming up with the algorithms and the code to run this calibration process efficiently and not consume thousands of US$ on cloud compute time is also, I think, a valuable contribution to this challenge.
Great, thanks for those answers. We are coming up on the end of the scheduled time slot, but if there are more desperate questions, now's your last chance to throw them in the chat. So we have one from Jane. If we're willing to help with data collection, how do we go about it? So maybe that's for all of you, and more broadly, are there open calls or places that you could use help from all of us? And if so, how do we find that? And maybe that'll be something for us to actually share as Zindi, because it's not so suited to voice. We'll try and put out some links for anyone wanting to help or wanting to get in contact with these different efforts. We'll post that after this session. Okay, we have another question. Assuming that the number of tests carried out isn't a factor, do you think that previous immunizations like BCG play a part of the slowed spread of COVID in Africa. So I think this is coming from a point of view where we've all noticed the numbers in our locales seem a bit lower than those in, say, Europe or America. So this is a question whether this previous immunization might be one of the causes for that.
I think this is something that we don't know yet, but certainly could play a role. And you also imagine in populations where there's a greater proportion of younger people that have more recent to their BCG vaccination. So like if your average population age in a country is 20 something, it's a lot different than, in that country, there was a BCG policy compared to a country where there's also a BCG policy, but the average age is closer to, late 30s. You'd see a different protective effect. But I think that's something that is certainly, I think, still plausible, but unknown. And, an alternative explanation could also be testing capacity, because we generally see the number of cases increase linearly with increased testing capacity across the world. So I think that might be another limiting factor or potential explanation. But I hope BCG is helpful. That would be great news. But I guess we'll find out. Yeah, fingers crossed.
Wim, you had something to add?
Yeah, I think that population density and population mobility are also important factors. I think that New York is way more connected and people live closer to each other than in a lot of parts of Africa, and that also explains the big differences.
Great, thank
you. And the use of these giant public transport systems. So like New York City, right? Everything is super connected, and the rate of spread was intense. But whereas Los Angeles, also a huge city, also dense, but also no big public transport. So I think that can be a huge driver. And so, a lot of cities don't have these intense, of course, metros that New York City does. So in a way that's protective, even if annoying, if you want public transport.
When I think of like populated areas in Africa, I think about the markets. If you've ever been to a market in Lagos, like people are so closely packed together. Those are the places where I think that transmission can occur very quickly.
Yeah, and I agree with that completely. And I also wonder, let's say BCG does provide some protection in the event that is true, that not everyone will have sufficient immune response, just from what we know about vaccines in general. And so when you have people packed together like that in a market setting or in a shared communal resource setting, that even should BCG, for example, be protective, that you'll have enough people that don't have immunity in some way, that will still enable outbreaks at that level. Yeah, linear scaling, you're right.
Everyone's already noticed the question in chat, but the question was from Mitch: considering that we're all still below 5% of the total population infections, can we assume that what the models predict now will scale linearly from this point? And if not, can we still gain insights from these models? I think part of this is not will the number of cases scale, but can we draw useful information even when the number of infected is fairly small, like we're seeing in South Africa or Zimbabwe? I think we 34 recorded cases. So can these models tell us what's going to happen down the line when there's lots of infections, or do we almost need to wait for more data?
That's a tough one. So 34 cases sounds not enough, especially I don't know how they are distributed. If they're all over the place, that doesn't sound enough. If they are clustered, that's probably the beginning of a local epidemic. But 5% of a country is a huge amount of people infected. So I think in South Africa, it doesn't really. It's not a problem for inference that less than 5% of the population is infected. I think it's the trends are solid enough to really fit models too.
Great, thank you so much. All right, everybody. I think we might have 1 or 2 more questions, and we'll get back to those after this. Oh, one final question. Has anyone tried Monte Carlo Markov chains? We'll use this as our last question, and then I'll sort of wrap up. So if anyone wants to chime in on that, otherwise we can call this good.
Anyone, yes, but not me.
I haven't used it for, I mean, I've used it for other things, but not for modeling COVID.
I also haven't used it for COVID.
So Webster Gova, who asked the question, maybe that can be your homework assignment. Okay, thank you so much, everybody. On behalf of Zindi, I'd just like to say we're so grateful for our panelists giving such time and insight for us. I think it's been really useful, and it's sort of encouraging to see that there's so much work being put in on so many different fronts, and that there's ways for us to contribute and help, whether that's joining a team doing some of this modeling or trying to find extra data that's useful as inputs. So this has been a very, very useful session. Paul, I don't know if you want to thank some of the other people involved in putting together this webinar and the competition and bringing everyone together. So maybe if you're around, do you want to just do the sort of final close off?
Yeah, cool. Thanks very much, Jono. Yeah, so to echo what Jono said, thank you to our panelists. I think the insights were fantastic, and I think epidemiological modelers may be some of the busiest people in the world right now. So it's really great that you've given of your time for us like that. So thank you so much. Thanks also to Our Ladies Cape Town and to the Cape Town Machine Learning Society for partnering with us on this event. And thank you to all of you who showed up to listen and to learn. I hope this can start a conversation. Please do send us any more questions you have. You can post questions onto the discussion forum, or send them to us via social media, or even our email address, zindi@zindi.africa. I definitely think we'll be taking some of your suggestions on board in terms of how data scientists can help and what kinds of data and what kinds of model will be useful. So yeah, I hope this was informative and interesting to everybody. Don't forget to apply for the data science internship if that's something you would like to get involved with. And I think with that, I can wish everybody a very good evening and say thanks and good night.